Welcome back, everyone. We're going to continue our airway series with a discussion of an airway device known as a BIAD. A BIAD describes an acronym for Blind Insertion Airway Device. And it's a group of tools that we use within EMS to assist in ventilation when bag valve mask alone isn't the most efficient means to ventilate a patient. The most common BIAD that we use in EMS is the King LT airway. The King LT, or King as it's often called, is a latex-free, single-use, single-lumen device used to assist in the positive pressure ventilation of apneic patients. It does offer some airway protection, although the airway protection offered is not as good as an endotracheal tube. So if airway secretions or emesis is of grave concern, this device will not be most effective for management of that patient. However, in the unconscious apneic patient, this tool can aid in delivering effective ventilations to the lungs while minimizing gastric distension when used appropriately. The King LT airway is a curved tube with ventilation ports between the two inflatable cuffs. You can see the distal end of the cuff on the patient mannequin here is inserted directly into the esophagus. That cuff inflates and helps occlude esophageal reflux and ensure ventilation makes it into the trachea. The more proximal balloon at the top end of the King LT inflates into the oropharynx area, and then ventilations are delivered directly between those two balloons in a port that delivers air into the lungs. There are a couple of types of King devices. There's the King LTD and LTSD that are both used for adults and pediatric patients, and there are 5 sizes of each type. The indications for the King LT airway are as an alternative to bag valve mask ventilation or rescue breathing when ventilations are not sufficiently achieved with a bag valve mask and simple airway adjunct alone. It has the same considerations as its predecessor, the combi tube, but combi tubes are rarely seen on ambulances today. As far as contraindications for the King LT, patients with an intact gag reflex, patients with known esophageal disease, and patients who have ingested a caustic substance, we would not want to use this device for. And much like our discussion with the OPA, if a patient has an intact gag reflex and we're going to use a device that could stimulate that gag reflex, we could cause significant problems with that patient, mainly vomiting or emesis, which could further occlude the airway. So we won't want to use these with patients with a gag reflex. The esophageal disease, we could cause significant trauma when using this device. And as far as caustic substance as a contraindication, we don't want anything that's going to perhaps damage the device and make it work less effective or be ineffective completely. As far as the insertion technique goes, we'll go over the step-by-step procedure in lab, but there's a few things that you need to keep in mind. One, the patient's height and weight determines the size that you're going to use. For this device, it's predominantly based on the patient's height because the weight does not correspond to the diameter of the airway as much as height does in the average patient. You note here that in the insertion technique, the provider has inserted a thumb into the mouth and has their fingers on the bottom of the mandible. It's important when we're inserting this device to remember to move the teeth out of the way, and if the patient is unconscious, we'll use this method to pinch the mandible and lift and move it away while we slide the device in, as to not rupture those balloons to ensure we get an adequate seal. You can see on the bottom of the screen here the sizing and color connectors are coded for patients of various heights. So for example, a size 3, or the yellow connector, is for a patient between 4 and 5 feet. The size 4, or the device with the red connector, is 5 to 6 feet. And 5, the purple, is for greater than 6 feet. Note there's also specific amounts of air and pressure that should be achieved in each of the balloons upon inflation. In all 3 of those sizes, the pressure should be 60 centimeters of water. There are some complications to be aware of with the King LT device. And you can see here another side view where we've got the proximal balloon in the oropharynx We've got the distal balloon in the esophagus and the ventilation area between those two devices where air will enter into the trachea. So complications of the King LT include laryngospasms, or contractions or spasms of the laryngeal area, vomiting, particularly if they have an intact gag reflex, and hypoventilation. And this typically occurs if the device has been inserted inappropriately. Trauma from an improper insertion technique, and the pharyngeal balloon, or the proximal balloon here, may push the epiglottis over the glottic opening, in which case you would not be getting sufficient ventilation. It's always important with any of the BIAD devices or any intervention to reassess your patient continuously to ensure that you're getting the appropriate treatment and the expected response from the patient. Now let's talk about some other less common devices that are seen on the ambulance. The next one is the laryngeal mask airway, or the LMA. This is an option for patients who require more support than a bag valve mask but may not yet require intubation by an advanced level provider. Similar to the King LT, it provides a conduit for air to go into the glottic opening, and it's more of a focused delivery ventilatory support device. Similarly to the King, the LMA does not provide direct airway protection. So again, if emesis or hemorrhage or occlusion is a concern, you may need to reach out for ALS support to ensure these patients can be intubated to appropriately secure the patient's airway. The LMA surrounds the larynx opening with an inflatable cuff. And you can see here on your screen that the cuff is inserted just at the glottic opening, and it inflates to seal off the area and deliver ventilations directly into the trachea, much like the King LT. As far as indications and contraindications, they're very similar to the King. They're an alternative to bag valve mask ventilations. A consideration here is that the LMA can be less effective in obese patients, and pregnant patients and patients with hiatal hernias are at risk for regurgitation. And it's ineffective with patients that require high pulmonary pressure. And this is because the seal that's created with the mask, the LMA piece, the balloons, if you will, is not appropriate to deliver high ventilatory pressure. Some advantages and disadvantages. It does offer better ventilation to the patient than a bag valve mask alone. There's no continual maintenance of a mouth-to-mask seal. There's no direct laryngoscopy or the need to directly visualize the placement of the tube, such as in orotracheal intubation. And it does somewhat protect from secretions, although again, it's not a definitive protection device. That was only achieved by an endotracheal tube. Some disadvantages for the LMA: there's no protection against aspiration. The air may be insufflated into the stomach, which is a similar complication we have with all ventilation devices. And it's not considered a primary airway device in emergency situations to secure the airway. Elaborating on some of those complications, as far as the involved in the regurgitation and aspiration, we'll weigh those risks against the benefits of hypoventilation. So in the event that we can't adequately ventilate with a bag valve mask and simple airway adjunct alone, the risks of regurgitation and aspiration may be outweighed by the risks of hypoventilation and that inability to ventilate that patient. Again, not being able to ventilate with a bag valve mask directly, if the patient may need high ventilatory pressures, the risks may outweigh the benefits, or the benefits may outweigh the risks in using that LMA device. As far as the equipment specifically for the LMA, there are several sizes, in this case based on the patient's weight as opposed to the height. There's a tube and an inflatable mask that sits in the larynx. The proximal end is fitted with a standard adapter, so you can attach a bag valve mask to it, or a ventilator-assisted device or ventilatory assistance device. And there's 2 bars at the opening of the LMA, which can help prevent occlusion. One of the benefits of an LMA is that some LMA devices allow the passage of advanced airway devices through them. so we can use the LMA to later assist in intubation of a patient or the passing of an oral tracheal tube or passing through a device that will again assist us, such as a bougie device. You can see here that the cuff has a one-way assembly, so when it's inflated, the mask will stay full. And as mentioned, the 6mm ET tube can typically pass through a 3 or 4 LMA, so that may help in subsequent airway management by the advanced provider. And you can see the two lines here that prevent, those two membranes, if you will, that help prevent regurgitation and inhalation of foreign material. And another image of some varying types of LMAs here that you can see. The last one that we'll talk about is a more recent device to make its way into EMS, and it's the iGel. The iGel is similar to the LMA in that it sits at the laryngeal opening, or the opening to the trachea, and it seals the pharyngeal, the laryngeal, and the perilaryngeal structures similar to the LMA, but the primary difference is it's not inflated. This avoids some of the issues associated with excessive compression of tissue from overinflation, and some of the guesswork with ensuring that your inflation gets an adequate seal in the tracheal opening. Again, this device does not adequately protect the airway against heavy secretions, emesis, or bleeding. It does have some additional features such as an integral bite block and a gastric access channel, which allows the passage for advanced providers of an OG tube for decompression of the gastric. And it has a supplemental oxygen port for passive oxygenation. This device is sized by weight. Again, you can see that size 3 is for 66 to 132 pounds or 30 to 60 kilograms, size 4, 110 to 198, and a size 5 is for greater than 198 pounds or 98 kilograms.